Good morning. This is Dr. Joe Moscato of the Missouri Cancer Associates on another of a series of talks for the Boone Hospital nurses. This will be on pleural effusions, a really very common problem we see on 2100. Now, there are multiple pathways of pleural fluid turnover, but the common pathway is for fluid to flow from the pleural space next to the lung, where one can see small vessels and fluid accumulating through the pleural surface into lymphatics. And there's normally a significant amount of fluid that's made each day and needs to be drained. Now here's a CT scan of a typical pleural effusion. This one is bilateral effusions in a patient with breast cancer, and one can see the grayish area lying posteriorly in the chest with the effusions and compressed lung above it. Now the approach to malignant pleural effusions can be multiple. The effusion, of course, can be malignant or paramalignant, caused by the cancer but negative pleural fluid cytology, but the management is somewhat similar in these patients. Now, the first thing we have to decide is what's the patient's prognosis. If the patient has only a few days or weeks to live, it's going to be treated differently from a patient who has a longer survival or is more up and around. So the first question is, should it be treated at all, or are we just going to palliate the patient completely? What are the treatment options, and how do I know which option is best for my patient? Now, if the prognosis, as I say, is short, one can treat with comfort measures and morphine and just get by. We see many asymptomatic effusions. They don't really need treatment. Many will reach a steady state and not cause us any more trouble. But if symptomatic, therapeutic thoracentesis should be done for relief and diagnosis. Thoracentesis may be done under ultrasound guidance or at the bedside. It may be somewhat painful, but lidocaine is used. One needs to avoid the vessels and nerves that run under the ribs. If more than 1,500 to 2,000 milliliters are removed, there may be some fluid shifts and occasionally pulmonary edema, as we noted before. The appearance of the fluid can be straw-colored, chylous, or bloody. Cultures and gram stains should be obtained, as well as pH and cytology, protein, glucose, LDH, cell count, and diff, and sometimes triglycerides if we think it's a chylous effusion, and ANA if it's potentially related to rheumatoid arthritis, and occasionally some people obtain creatinine and amylase. Pleurodesis is a procedure that obliterates the pleural space in order to prevent recurrent pleural effusion. It is most commonly performed by draining the effusion and then instilling a chemical irritant into the pleural space, which induces inflammation and fibrosis. As an alternative to chemical pleurodesis, the pleural space can be mechanically abraded during thoracoscopy or thoracotomy. This is known as dry abrasion pleurodesis. So one can use a chest tube, or one can take the patient to the OR and drain it that way and accomplish the same process. Now, chest tube pleurodesis is a commonly used technique, a little bit less than before, but a chest tube is placed and the pleural space is drained. You have to pre-medicate the patient with morphine and Ativan or Versed because it is a painful procedure. The lung must be completely expanded or the procedure will not be successful. And once the lung is expanded and once drainage is decreased to less than 150 milliliters per 24 hours, a talc slurry is instilled, and some people, like me, like to rotate the patient, almost like a rotisserie, to make sure the talc distributes evenly. After the talc is placed, you place the tube back in suction. Remove the chest tube when drainage is less than 150 milliliters for 24 hours, but no less than 24 hours after the talc. And the whole procedure may be repeated in 2 to 3 days if the drainage is still greater than 150 milliliters per 24 hours, with the chest tube still in, obviously. The complications of chest tube pleurodesis can be pain, inflammation with fever, failure to sclerose the effusion, Rarely, as we noted, unilateral pulmonary edema and bradycardia, chest pain, and syncope can be seen with the chest tube placement. Thoracoscopic sclerosis requires general anesthesia and intubation. Allows for visualization of the pleura and better biopsies if that's indicated. Dry talc is instilled into the pleural space. The success rates are somewhat higher, but of course it's also a selected population. Most commonly now, I think, we're using Pleurex catheters, an alternative to chest tube drainage. This is a method to intermittently drain effusions rather than sclerose the pleural space. Generally, this can be done with a one-day hospitalization, but the patient goes home with this small catheter in place and needs the bottles to. I think you're familiar with these. The bottle is used as a vacuum bottle used to drain through the Pleurex catheter, which is a one-way valve. And generally, these bottles are unfortunately quite expensive, I think in the range of $35 to $40. So that can be a limiting factor, especially in terms of a hospice patient. Drainage is often every other day initially. Sometimes it gets down to once a week. So pleural effusions are common in malignancy. Decisions to treat are based on symptoms and life expectancy. The diagnosis is based on the thoracentesis, and the methods of sclerosis include chest tube sclerosis, thoracoscopic pleurodesis, or Pleurex catheter, which ultimately can cause sclerosis in addition. Thank you very much, and as usual, if you have any questions, please don't hesitate to stop us and ask. Thanks very much.